So renal stuff. So we'll do a quick renal A&P review. We'll talk about osmolality and electrolyte movement. And then we'll become a thought leader in your customer sphere because I forgot to take that part off the slideshow. So I thought this guy's video was really good. It's about CRRT, but there is a section on kidney A&P that I think is helpful.
And so to start, let's begin talking about some of our renal anatomy. Now, as we know, the organ of the renal system is the kidney, which we have two of. They sit in our retroperitoneal cavity on each side of the spine between the 12th thoracic and 3rd lumbar vertebrae. And just interesting to note, the right kidney is actually lower than the left due to the placement of the liver. Now, we can divide the kidney up into three layers. We have the cortex, which is this outer layer here. Next, we have the medulla, which is going to be this inner sort of open section here. And then finally, we have the renal pelvis, which is going to be this area here. And this is where the urine is collected and sent to the urethra. Now, the cortex and the medulla, they contain various parts of the nephron, which is actually what we're going to talk about here next. And so the nephron, this is our functional unit of our kidney. And so what's really interesting is that each kidney contains more than 1 million of these nephron units in it. And collectively together, that they work to maintain the water, electrolyte, waste, and acid-base balance in our body. And the way that they do that is through this pretty complex structure that you see that I have the picture of here. And so let's go through and talk about some of the different parts of this pretty complex nephron structure. So the first is going to be this big capsule-like structure here. And this is going to be something that we call the glomerulus. And as you can see, it's surrounded by this membrane, something that we call the Bowman's capsule. Now, the first section coming out of the glomerulus is going to be our proximal tubule. And then continuing on from here, this is actually still technically part of the proximal tubule, but this is something that we call the loop of Henle. And the loop of Henle is composed of three sections. We have the thin descending loop, the thin ascending loop, and then the thick ascending loop. And then from here, we go on to the distal convoluted tubule before finally going into the collecting tubule and the collecting duct. Now, important to go along with the tubules of the nephron is also going to be the renal blood supply that we have going through here. And interestingly, 20 to 25% of cardiac output is going specifically to the kidneys. And so everything really begins with the renal artery branching off the aorta. And so we can see that coming in on the image here on the right. And then from there, it's going to branch down until we have something that we call the afferent arterioles. And this afferent arteriole is going to be what enters the Bowman capsule and really helps to form that glomerulus. Now from there, the blood is going to exit the glomerulus via what we call the efferent arteriole. And then the efferent arteriole is going to become this pretty big complex, something that we call the peritubular capillaries. And really, these peritubular capillaries are going to interface with all the different parts of the tubules to continue to perform functions that need to happen within the nephron. Alright, so now that we have the basic structures out of the way, let's talk about the actual renal physiology that's taking place here. And so the main goal of the kidney here is to filter the blood and form urine. Again, like I said, in this process, the nephron's going to be regulating water, electrolytes, waste, and the acid-base imbalance. So, like I just talked about, the afferent arteriole is what goes in and forms the glomerulus, which is actually a high-pressure capillary bed to which then the blood exits via that efferent arteriole. Now here, the afferent arteriole is actually a larger diameter than the efferent arteriole, and this is what allows a greater volume of blood to enter the glomerulus than what's actually exiting, and this is going to create a high pressure. And it's specifically this high pressure that creates the hydrostatic pressure, allowing water to be filtered across the basement membrane. And so then the basement membrane of the glomerulus is actually a semi-permeable membrane, and it's going to allow all but the larger molecules to pass through it. So think here we're excluding things like protein, albumin, red blood cells. And so here we're going to have particles that are small enough to pass across the basement membrane, which are going to be moving from areas of higher concentration to lower concentration. And this is also something that we call diffusion. Now on top of that, if we have enough water that's being forced across that membrane via that hydrostatic pressure that we just talked about, additional particles or solutes are also going to be dragged along with it, something that we call convection. And so typically with our kidneys, large volumes of water are going to be filtered, allowing for this additional waste clearance that we see. So now we have blood that's left with these large molecules and proteins, and it's going to be leaving via that efferent arteriole. Now, having these large molecules and proteins in there is actually going to provide oncotic pressure for water and solutes to be reabsorbed in those peritubular capillaries. And so, as you can see, the blood that's exiting via the efferent arteriole is still oxygenated blood. And so, in addition to also going into those peritubular capillaries, another responsibility that it has is to actually perfuse the kidney itself. And that's why finally at the end here, we do see the blood becoming deoxygenated as it goes out into a vein. All right, so like we talked about, we have that high volume of water filtrate that has left out of the glomerulus. And first we're going to enter into the proximal tubule, and this is going to be responsible for the reabsorption of water and important solutes and electrolytes. And here we're talking about things like potassium, sodium, chloride, glucose, and bicarbonate. Now, on top of this reabsorption, we also have hydrogen ions that are going to be passively secreted here. Now, continuing on, we actually have different nephrons that have different responsibilities for what actually takes place in the loop of Henle. So we have shorter cortical nephrons, which are going to focus on the excretion and regulatory functions, while we have longer juxtamedullary nephrons, which either dilute or concentrate the urine depending on what needs to happen. Now, if you remember looking at the loop of Henle, there's a big distinction between parts 1 and 2 and part 3 in terms of the thickness, and it's this thickness of the loop of Henle that actually impacts the permeability of the membrane, allowing it to do different things. So then moving on, we have the distal convoluted tubule, which plays an important role in the regulation of blood pressure, while also regulating solutes by absorbing or excreting them in this section. And in this section, we also have the antidiuretic hormone, or ADH, which aids in water reabsorption towards the end of this distal convoluted tubule. Now, we do see some bicarb being reabsorbed here, as well as hydrogen ions being actively secreted. And then the main waste products that we're looking to excrete through this active filtration by the nephron are going to be our BUN, uric acid, and creatine. And so as you can see, the kidney and their functional units, the nephrons, really play that vital role in the homeostasis of our bodies. They're regulating the fluid balance by controlling how much water is reabsorbed. Waste, electrolytes, and solutes are going to be filtered out, but then the regulation of the electrolyte solute reabsorption is going to take place to ensure that our body has proper levels. And then also through the reabsorption of bicarb and the secretion of those hydrogen ions, they're going to be working to regulate the body's acid-base imbalance. And so when our patients go into acute kidney injury and ultimately renal failure, this important regulation really becomes ineffective or non-existent. And in order for us to be able to support these patients, we really need to recreate the work of what's happening inside this nephron. And so much of what we attempt to do with the therapies that we offer is based on what the natural nephron is doing. And therefore, having an understanding of what normally happens in here is going to be important to understand the how and why the therapy that we provide does what it does. And so that's why I wanted to do this renal system review for you guys, so that you had this understanding of what was going on here, because as we move forward and begin to talk about CRT and how that works, much of what's going on there is really driven with the purpose of trying to recreate what happens here so that we can effectively filter the body's waste, as well as controlling the fluid balance, as well as the electrolyte and solute balance of the body, as well as having an impact on our patient's acid-base balance. So I hope this was a good quick review of what's going on here in the renal system. Like I said, we're going to apply this in.
So I like having his just kind of overall review before we talk about electrolytes and osmolality specifically. So I'm going to move us along here. And so when we're talking about osmolality, I wasn't sure if the question was related to urine or serum. So this is from ECHO, which we use for orientation. And it just describes the different types of osmolality you might be looking for. So you've got your serum osm and your urine osm. So it's the concentration of particles if we're talking about urine, and the concentration of solutes in the serum if we're talking about serum. And so your osm for, which I thought was kind of interesting, because we don't always order it on patients, but it roughly is double your sodium level. So if you get a BMP on any patient, you should be able to just kind of give a guesstimate. So if you have a patient who all of a sudden you're seeing a ton of urine tick up, then you might be concerned about DI, you can just take a look at their trend of their sodiums, and that'll at least give you a start before hopefully things get particularly awful with DI. Just a quick review of volume status. So when we're talking about excess and deficit, when we're giving either an isotonic, hypotonic, or hypertonic solution, just remembering what causes what. So if you're giving a hypertonic solution, you're going to be dehydrating the cells because you're pulling all of the water across to this concentrated area. The intravascular volume is going to be really concentrated, and so your cells are going to shrivel. So when we're talking about a neuro patient, so if you get a neuro question and on the test and it's asking about a patient who's got a lot of extra cellular fluid on the brain, you might be giving 3%, which Inga is probably familiar to you. Probably do that frequently. And then if we're talking about a patient who is looking to have, they've got concentrated inside the cell, we can move it by giving a hypotonic. I don't feel like we do this super often. And then obviously most of the time we just try to give an isotonic solution. So I think Judy's question was about urine osmolality. So this slide I thought was helpful in talking about, increasing versus decreasing what the body is doing in relation to fluid volume. And then AKI, because that was something that we see often and that she had asked us to cover. And again, these slides are directly from ECHO. The guy for CRRT is actually from ICU Advantage, and they have a ton of videos if you're looking for other stuff to get educated on. This is Dr. Mike and Dr. Matt from Australia. One, I like their accents, but two, I think their stuff is actually pretty good.
That means that whatever fluid...
So I skipped ahead because he does spend a lot of time setting this up. So anywhere you see ICF here, this green, he's talking about intracellular fluid. ECF here, he's talking about extracellular fluid. This is the capillary that he's talking about here, and he'll refer to this area, the extracellular fluid, also as the interstitial area, and he'll refer to the fluid in the capillary here as plasma.
Is in the ECF, meaning in the interstitium, is going to be easily exchangeable with the fluid in the blood plasma. Okay? Now, again, why is this important? Well, because whatever concentration of stuff or solutes is sitting here between the cells is going to be the same concentration of solutes in your blood plasma. Exceptions include red blood cells, white blood cells, and some proteins. Okay? These are too large usually to go out or in to these blood vessels. Okay? But what does get exchanged here? Well, very importantly, the substances or solutes that gets exchanged between the interstitium and the blood plasma include all the different ions of the body. Okay? So, what I want to do is list or label the important ions of the extracellular fluid and then label the important ions of the intracellular fluid. Okay, so ions of the extracellular fluid. Well, they include sodium, calcium, chloride, and bicarbonate. So these are some of the major extracellular cations, positive charged ions, and anions, negative charged ions. So what are the most common or most abundant intracellular cations and anions? Well, just get rid of that. Well, the most abundant intracellular cation is potassium. Okay. There's also magnesium. For the anions, there's phosphate, and there's negatively charged proteins. Okay, so what you can see is two most abundant extracellular cations, meaning the two most abundant positively charged ions that sit outside the cell, is sodium and calcium. The two most abundant intracellular cations is potassium, magnesium. The two most abundant extracellular anions, chloride bicarbonate, and the two most abundant intracellular anions is phosphate and proteins. Now, remember that this partition is important because they're not easily exchangeable. Why? Because all cells are surrounded by a phospholipid bilayer. That means a fatty layer. This fatty layer, remember, does not like charged substances. Ions, by definition, are charged, which means they get repelled. So the potassium inside cannot just diffuse out, it bounces off the walls and remains inside. The sodium that's outside cannot just diffuse in, it will bounce off the walls and stay outside. They need certain channels to let them through. So that means that the concentration of sodium outside will not be reflected by the concentration of sodium inside, and the concentration of potassium inside will not be reflected by the concentration outside. However, because the blood plasma or the blood vessel does allow for exchange between the interstitium and the blood plasma, that means that whatever concentration of sodium is in the interstitium, that will be the concentration of sodium in the blood vessel. So for example, if I were to just extend this blood vessel out, the concentration of sodium outside the cell is going to be the same concentration of sodium in the blood vessel. The concentration of calcium outside the cell is going to be the same concentration of calcium in the blood vessel, and same with chloride and bicarbonate. The clinical significance of this is when you test a patient's blood serum for electrolytes, for example, you take it from their blood, okay? So you draw it out of here, and what is it measuring? Well, it's going to tell you sodium concentration of calcium and chloride and bicarbonate and so forth, and potassium, and you may think, but potassium's in the cell. Well, yes, but there is some potassium outside. And it's going to be a reflection, when you take this blood and measure, it's going to be a reflection of what's happening between the cells as well. Whatever the concentration is here is the concentration here. Now again, this is important because even though these ions are not exchangeable, so I'm going to now wipe this off and redraw it. So let's just focus on sodium and potassium. So even though this sodium cannot get inside the cell and this potassium cannot go outside the cell, what can actually be transferred between the two is water. Okay? Now remember, if diffusion cannot occur, osmosis will if there's a concentration gradient either side. Okay? So think about it. If a patient had altered electrolytes, okay? Now, firstly, it's important for you to be aware that overall, remember I said you've got sodium, you've got calcium, you've got bicarbonate, and you've got chloride. And I said inside the cell you've got, what was it, potassium, magnesium, phosphate, and negatively charged proteins. Well, did you know that the concentration of all these solids inside the cell should match the concentration of the solids outside the cell? And the concentration is, dropping stuff, 290, you need to remember this number, 290 milliosmoles. Now that just means basically the concentration of solutes in 1 litre of fluid. That's what that means. And it's 290 milliosmoles. That's outside the cell, and that's inside the cell as well. Now, let me very quickly tell you how we got to this calculation. You will not need to know this for the exam, but how do we get to 290? Well, one of the calculations plus the glucose concentration plus the, what should be the concentration of potassium per litre, plus 5. When could this change? Well, if I increase the amount of sodium, if I increase the amount of potassium, or glucose, or urea. Remember, these are just substances or solutes dissolved in the fluid. So we can change this concentration right here by changing the concentration of these solutes. Okay, now, in the next video, I'm going to talk about what happens in the body when this concentration changes. So for example, I'm going to prep the next video by telling you, let's just say that you haven't drunk water for about 12 hours. What do you think happens? When you don't drink water for 12 hours, that means that your body uses water up, right? It's going to excrete it in your urine and in your fecal matter and while you breathe and so forth, and it's going to use it to make energy, okay? Which means the fluid in your body, particularly the fluid in your extracellular fluid, drops. But what about the solutes? Well, in actual fact, your solutes will remain around about the same. It's just that the water level drops. So if you were to, I always think of it as though it's in a bucket. And here we've got all the solutes inside of this water. And this is normal. So you're not thirsty, you're hydrated. This is how you want to be. Perfect. But let's just say you start to become dehydrated and you're not drinking any water. Well, the fluid drops, but the solutes stay the same. So what happens? Well, the fluid level drops, but now you've got the same amount of solutes. What happens to the concentration of that fluid? Well, firstly, it's not very good, but the concentration goes up. So that means 290 milliosmoles may move its way up to 320 milliosmoles, for example. Now look at that. If you have 320 milliosmoles concentration outside the cell compared to 290 inside the cell, there's a concentration difference. And you know that when there's a concentration difference, things want to balance themselves out. And you think that sodium will want to diffuse in and calcium will want to diffuse in, and they do, but they can't because of the plasma membrane. So what happens? Water will try and balance it out. And just remember, water will go wherever there's a higher concentration of solutes. Where's the higher concentration of solutes? Outside the cell. So that means water from inside the cell moves out. What do you think that means to the cell? It shrinks. Remember I told you last semester that when a cell shrinks, it's called crenation. Okay? Now, I'm going to tell you in the next video how our body responds to this scenario.
On mute. So that's Dr. Mike's kind of overall explanation. I think that part at the end is really important because once we see that shrinkage of the cells and we see the leaching of the body, that's when we start to experience things like cell death or cardiac abnormalities or mental status changes. And so I'm going to pull this over just 1 second. So give me 1 minute here. I won't be able to get it to work since I'm on screen. All right, so hopefully you can see this. And so I'm just going to walk quickly through because I think this does a really good job of talking about hyponatremia, signs and symptoms, aldosterone insufficiency. So if you're talking about a patient who's got an aldosterone issue in your test, that might be one of the issues. Signs and symptoms, the big one is going to be mental status change because, again, water follows sodium. So if you've got more sodium concentrated inside the cell than outside the cell, the water is going to move into the cell, and then vice versa. If you've got a ton of sodium outside the cell, your cells are going to get really dry, and that's when we get those dehydration headaches. So obviously, our goal for hyponatremia would be to fluid restrict because these are patients who've got a low sodium, so they've got a lot of water. Give them diuretics, hypertonics, obviously, if the patient's extremely low, but then remembering that we want to correct only 8 to 12 milliequivalents per 24 hours because you can have demyelinating effects on your neurons if you overcorrect your sodium too quickly. And that was one of the questions that I saw when I was looking to prep this material today was how fast to correct a patient's sodium. 2 or 3 of the prep books I looked through asked you how many milliequivalents per hour you should be giving. So definitely keep that in mind as it should only be corrected 8 to 12 milliequivalents over 24 hours. Again, making sure that you administer isotonic fluids unless you're really got a severe hyponatremia and then giving hypertonics. And then monitoring for neurostatus, any sort of mental status change, seizures. I would expect to be doing OSMs pretty regularly, and then fluid restriction. And so again, 8 to 12, you're going to see that over and over again just because that's definitely a question that will probably come up on your test. Yes, an osmotic demyelinating syndrome. So if you ever talked to Courtney, who used to be a PA in the MICU, that was one of her big things that scared her about neuro patients was overcorrecting quickly. Alrighty. So if we were talking about a patient who's got heart failure and pulmonary edema, and we were giving we were treating hyponatremia, what do you guys think would be other complications?
Mental status changes.
Yep, and one more.
MI maybe?
Yep. Nice job,
Wow.
Sophia.
Thank you.
So patients with cardiovascular dysfunction, obviously you're going to monitor EKG because the patient doesn't tolerate fluid or it mobilizes too much fluid and the heart gets overloaded. Nice job. Thank you. So hypernatremia, you're going to see obviously elevated. So if you've got a patient who's got excessive volume loss, so your patients who are nausea vomiting, excessive sweating, patients who are febrile, so they've got all of that tons and tons of sweating. Some of your patients on behavioral modification drugs, particularly antidepressants, might be asked to take salt tablets because antidepressants one of the side effects is that they can cause low sodium. So you might see a patient with hypernatremia in that case. Obviously, if we do it by giving sodium bicarb or hypertonic saline, and then, of course, dehydration, we already talked about vomiting, but DI, heat stroke, and inadequate fluid intake. So even our patients who are hospitalized but maybe aren't getting up to drink as much as they normally do can be at risk for hypernatremia. Back here just for a second. And so since water follows sodium, you're going to see altered mental status, seizures, muscle weakness, and then for DI, of course, diabetes means urine, so increased urine output, increased or decreased OSM, depending on whether we're talking about serum versus urine. So you're going to do large volumes. Again, don't correct rapidly. So your goal is to do it over 24 to 72 hours because you don't want to cause massive fluid shifts. And then expect to change again to D5 half normal, or D5 NS. And to evaluate, not anything we wouldn't be used to doing, so monitor vitals, urine, labs, level of consciousness, and then any safety measures. Questions at all about hyper versus hyponatremia? Up back here. So for potassium, obviously this is the definition of hyperkalemia. You may see it from NSAIDs, sulfas, and aldosterone issues. The first video we showed about the kidney talked about where in the kidney the actual potassium exchange occurs. And of course, there are cardiac impacts. So you will see peaked T waves. You can see them here. So if you're looking at the monitor or you get a question that's got an EKG in it and they may ask about electrolytes, just remembering that peak T waves can be something that you might see on the test as an indication for hyperkalemia. Prolonged PR, although I don't feel like they have you measure PR on the test. You get intraventricular conduction issues. So you'll see this wide QR complex starting to develop here. So you've got a peaked T plus a wide QR here too with the peaked T wave. Now everything looks terrible. And then bad news bears. So obviously we would hope to catch this in the real world beforehand, but I think for the exam specifically, knowing about the peaked T waves and the widened QRS is helpful. So obviously it depends on what's going on with your patient. I hate giving K oxalate, but obviously that would be something we would do. I always forget this, but you can actually use albuterol. So if that's one of your options on the test, you can use albuterol to decrease serum K because it drives it into the intracellular space. Obviously, we can give calcium, and then we can also give our favorite, D50 and insulin, and then you should be monitoring their QRS. Alrighty, so if I wanted to stabilize myocardial cells, do you think I'm going to use a loop diuretic, calcium, or bicarb?
Calcium.
Alrighty, and if I'm driving potassium into the intracellular space? How about if I'm excreting potassium?
Loop diuretics.
You got it. So by process of elimination, that should probably go there. Exactly. So just making sure that when you're test taking, remember that it's okay to eliminate things if you're doing a select all that apply, or if you've got something that's more A, B, C, D, trying to eliminate the ones that you know. So like, okay, I don't know what bicarb does, but I know calcium is important in the heart, and loop diuretics, we're always worried about their K and chasing their K when they're on Lasix. And so here's our patient who is going to give calcium gluconate, IV insulin, D50, and bicarb, along with, this guy's K must be like 10, obviously, with all these interventions. So what do you expect as evidence that his hyperkalemia is resolving?
One, 2, and 4.
Right, because you're going to have peaked T's, you'll have the widened QRS if it's still bad, and then he can progress out of sinus rhythm. So this is hypokalemia. Obviously, if we have an intracellular shift, or we have an issue where we're losing a lot of K, so vomit unfortunately has a lot of potassium in it. It's one of the side effects of lots of vomiting and diarrhea. Unfortunately, they're malnutritioned, so our alcoholic patients who don't get good diets, we'll see them. And then if you've got a renal issue, so neuro changes, paresthesia and muscle weakness, because again, K for duction issues, GI. So here you're going to see flat or inverted T wave. So you'd see a flipped T. You can see here the T wave looks really low, and then a prolonged QT. So again, if you've got a patient who's already got a risk for long QT syndrome, you want to monitor super closely for hypokalemia, and then your life-threatening dysrhythmias. So administering K, obviously, we're used to doing that. Checking an EKG, rechecking after infusion. So this should all be very familiar. This, I think, is helpful to remember. If you've got a DKA patient, you want to correct their K while you're correcting their pH and glucose. I know it says before, but you'll see a lot of times our DKA patients have fluids ordered with K in it. Because when we're giving large volumes of insulin, we can push that K into the intracellular space, and we can tank their K because we're giving a lot of insulin to help fix their potassium. Obviously, try to identify the cause. Make sure that we're monitoring QTC. So when you're doing your interval measurements for the test, keep an eye on QTC. And then things, obviously, that you'd want would be to see improvement in their K levels. If they've got some sort of dysrhythmia, that starts to resolve and that their EKG starts to look more normal. Talking about calcium, I'm not going to flip through all of that part because, obviously, we're not prepping for the NCLEX, but we're prepping for the CCRN. So if you have a patient who's got a thyroidectomy, their parathyroid was damaged, What 3 assessments might indicate that you have hypocalcemia?
Muscle weakness and spasms, dysrhythmias, and maybe hypertension. I don't know.
Yeah, me neither. All right. I'm going to go with bleeding disorders because I'm pretty sure the first 2 are correct that you chose, Inga. There we go. Oop, go back. There we go. So causes, again, the parathyroid is the big one, but you also might see it in sepsis and burns, liver disease, rhabdo, alcoholism, massive transfusion. So citrate, if you've ever given double reds or read about blood preservatives, citrate binds to calcium. And then we'll see hypotension, LV contractility, so we'll see poor cardiac output. So if you've got a patient and you get some sort of cardiac values in the test, that would be something to keep in mind is for calcium, obviously, and then seizures. So quick review on ionized versus serum. And the albumin level is really important. So Sarah O'Brien, who's in one of our dietitians, talks about this a lot. If you've got a patient who's either a liver patient or malnutritioned, their electrolyte calculations may not be correct for ionized calcium because the patient doesn't have albumin to actually bind correctly. And so if you've got a patient who has got a low calcium level, what would you expect to do for this patient?
The second one?
Oop, that one. Yep, we want to fix it. Nothing else in that list is going to fix it. And so you should see a resolution of MAP issues, because again, if your cardiac output is down, you're going to see a low blood pressure. Monitoring for dysrhythmias. And then any sort of, as Inga said, weakness or muscle issues should start to resolve. You've got high calcium, so it's leaching from the bones. Big for our patients here, at least at Leahy, for prolonged bed rest and immobility, causes leaching of calcium from the bones. Hyperparathyroid and chronic kidney disease. So those patients you'll actually see some sort of blood pressure abnormality, as well as potentially bradycardia with blocks. If they're taking DIG, which some of our patients still do, you might see DIG toxicity. You're going to see GI symptoms, and the same thing as you would with sodium. You're going to see changes in mentation, seizures, or hopefully not death. Hopefully we're not seeing death. And so if you've got a guy who's got an osteosarcoma, so that's a tumor of the bone, so obviously we're going to see alterations in calcium. We might use a loop diuretic. So that will cause the blood to be diluted to decrease so we're not changing the level of calcium, we're just trying to dilute it within the body, and then we can use CRRT or dialysis, but we have to use a calcium-free dialysate. So when you're looking at the bags, if you're doing CRRT, that's really important. Chelating, so using calcitonin or biphosphonates. And then corticosteroids. So if your patient's on chronic corticosteroids, something to keep in mind is their calcium level, especially if these patients are fall risks. And then giving phosphate. Again, you're going to see changes in their vitals when you're looking to resolve hypercalcemia too, particularly that T wave. So if you see peaked T wave, K. If you see flat or inverted, CA. I kind of remember that because a K has, I'm drawing it with my mouse, but of course you won't be able to see it, a straight line, but it kind of looks like a peak because you're drawing up, whereas CA, the A is down low, so it's flat or low. I don't know if that's helpful, but I'm a visual person. I try to picture anything to help me remember it. So Dr. Mike or Dr. Matt, I'm not sure which cute Australian we had that day when they were doing the video, talked a little bit about phosphorus. I can't say that I ever really thought about phos in our patients other than the fact that we just did it as part of our labs, but it's actually pretty important. One, for energy, because ATP actually requires phosphorus, and it maintains the cell membrane structure. And it's inverse between calcium and phos. So if you've got a low calcium, you may see a high phos. The flip side, though, is if you've got a high calcium level, your phosphorus is going to be low, so it's going to impact your energy production for all active transport. So just bear that in mind if you've got a patient with a high calcium level. So renal dysfunction is the big one, as well as antacids. So if you've got a patient who's got GI symptoms and they're popping a ton of Tums, you may see that they've got a low phos, and so their energy levels, and not just like their mental energy levels, but their cellular processes may be lower because there may not be an adequate amount of phos. Muscle weakness, respiratory failure, lethargy, again, low ATP, and then impaired oxygen delivery. And so you've got this lovely lady who's getting insulin infusions and hasn't been able to wean off the vent. Today her phos is low. What do you think that you would be doing for this person?
Three and four.
Okay. Do you think we would do CRRT or HD if we can remove calcium with it?
Oh, probably.
Potentially, I have no idea.
So
I haven't done this.
Well, it only says which two treatments, so.
Perfect. Thank you for actually reading the question. Awesome. So yes, you are correct. Those are the two you would use. And so that's it for phos, and then serum mags. So mag is the second most intracellular one. So in that video with the Australian doc, he was talking about intracellular versus extracellular. So what's the worst part about having a low mag? Neither one of you have been through orientation, so you may not have seen it. My orientation.
A low mag?
Yep.
A code.
Yeah, what kind of code?
Torsades.
Torsades, exactly. So every patient or every person who comes through orientation, it doesn't matter what they do, their patient goes into torsades, one, so they learn how to use the code cart, but also so that way they remember that they've got to give MAG. So
got it.
The big thing, obviously, would be a code. It helps transport K and sodium, and provides electrical stability. So that's why when you have a really low MAG, your cardiac electrical cells go completely bananas. Or I guess not bananas because you've got a low MAG. So patients, you'll see it, malnutrition. If you've got a large amount of drainage, or alcoholic patients, and then QT followed by QRS followed by disaster down here at the bottom, and then seizures. You might see hypocalcemia or hypokalemia, so you're going to see the side effects of those also. So that's why you might see those generalized weakness, tremors, and if you've got shifts in calcium, you may even see seizures. And so if you've got an unconscious patient who got K replacement and 2 grams of MAG, but his repeat level is only 1.3 and his K is the same, he's got prolonged QTC and is going out of torsades and then into torsades, what do you anticipate doing?
One and three.
What are you thinking? Yep, I saw that and go, thumbs up. Exactly. Because torsades is life-threatening, not compatible with life, and we want to ward that off by giving MAG. And so this is just how QTZ is calculated. Again, you should not need to know this for the test, but it's kind of nice to know. Fortunately, the Philips monitors do it for us, so we can be completely lazy. Lab changes. So when I first started in the ICU, we didn't actually do repeat MAG levels. We would correct it and then never actually bother to check. The new electrolyte protocol that came out like a year and a half now actually has us rechecking, maybe 2 years. And then again, your QRS and ST should be fixed, and T-wave should be the correct way up. All right. So if you see electrolyte imbalances that cause EKG changes or ECG changes, match one life-threatening dysrhythmia with each of the electrolyte imbalances. So asystole.
Is the first one hyperkalemia? I can't read it.
Yes, I'm sorry. It's
Okay.
hyperkalemia, hypokalemia, and hypomagnesemia.
Okay.
So asystole would be hypokalemia.
All righty.
VFib is hyper.
Where does torsades go?
Mag.
Not quite.
Ah.
So flip the VFib and asystole.
You got it. Excellent. Alrighty, so that is the echo on electrolytes that I think is kind of helpful, just to kind of go over a quick review of electrolytes. That's actually all the material I prepared for today. I'm going to stop sharing here for a second as soon as I find the button. Okay, I can see you guys again. Oh, there you are. Anything else that you guys wanted covered about renal, GI? I forget what else we launched this week. Behavioral, I think, by accident. Okay.
No.
So next week we'll be wrapping up. I think the only modules that we've got left are, give me 1 second here and I can take a look to see what we've got left. I've got 800 windows open, so bear with me. Oh, still not the right one. Are you snuggling, Inga?
Oh, so cute.
All right, so we have skin. That's it. So we'll do integumentary next week. Any other questions that people have? I had written miscellaneous as our last topic, so if there's anything as you're reviewing stuff that you're like, nope, I don't really understand it, either shoot me an email or you can put it in under skin and I will check for questions and stuff. But that's all I've got for today.
Awesome. Thanks, Sarah.
Yeah, thanks for being interactive today, even though it's only the two of you. It's nice.
That's okay. It's better that way.
Yeah, it's kind of nice.
Just kidding.
All right, guys.
Okay. Did you record that? I didn't want. Was that
I will chop
recorded?
it off the end.
Okay.